Hi everyone, I am Dr. Snehlata Verma, reader from the School of Dental Sciences, PBD University. In this video lecture, we will cover the serial extraction from the Interceptive Orthodontics. As we know, various disciplines of orthodontics include preventive, interceptive, corrective, and surgical orthodontics. And the Interceptive Orthodontics has been defined as a phase of science and art of orthodontics employed to recognize and eliminate potential irregularities and malpositions in the dentofacial complex. Corrective measures in interceptive orthodontics may be necessary to prevent a potential irregularity from progressing into a more severe malocclusion. Various interceptive measures that can be considered are written in this slide. The first 6 measures we have already spoken up in the previous 2 videos. Today we are going to discuss about the serial extraction, which is a very important interceptive procedure. These are the content from which we will talk about the serial extraction procedure. Serial extraction is an interceptive procedure usually initiated in the early mixed dentition. It is a procedure that includes the planned extraction of certain deciduous teeth and later specific permanent teeth in an orderly sequence and predetermined pattern to guide the erupting permanent teeth into a more favorable position. Whereas Duell defined it as an orthodontic treatment procedure that involves the orderly removal of selected deciduous and permanent teeth in a predetermined sequence. And the aim is again to get a well-aligned arches and a well-settled occlusion. Coming to the history of the serial extraction, it was the Jelgren who used the term serial extraction. He described it a procedure where some deciduous teeth followed by permanent teeth were extracted to guide the rest of the teeth into a normal occlusion. Whereas Nance during 1940s popularized this technique in United States of America and termed it as a planned and progressive extraction and has been called the father of serial extraction philosophy in US. Hortz in 1970 called these procedures as an active supervision of teeth by extraction. Rationale of the serial extraction procedure is that by predicting the lack of space at an early stage, we can plan the future treatment to accommodate all the permanent dentition so that there will be we can get a normal occlusion. Objective is to intercept arch-length discrepancy to reduce or eliminate the need for future extensive appliance therapy. So serial extraction is based on 2 basic principles: arch length tooth material discrepancy and the physiologic tooth movement. Here we have to judge about the arch length tooth material discrepancy, what amount it is present, and we want to guide the tooth in their designated position with more physiologic type of tooth movement. Coming to the indications for serial extraction. The cases with a class 1 malocclusion showing harmony between the skeleton and muscular system. That is, there must not be any skeletal deformation present. Arch length discrepancy as compared to the tooth material is the most important indicator for the serial extraction, as I said. Some abnormal eruption pattern and sequelae of lower anterior flaring will also be indication for the serial extraction. If there is ankylosis of 1 or more teeth, we can go for the predetermined sequence of deciduous teeth extraction. And if the growth is not enough to overcome the discrepancy between tooth material and the basal bone, we can also opt for the serial extraction. Patients having straight profile and pleasing appearance can be a suitable candidate for these procedures. And if the arch line discrepancy is the prime criteria for choosing the serial extraction procedure as our treatment planning, so there are some indicators which will definitely indicate there is a arch line discrepancy present. These includes if there is absence of physiologic spaces in the primary dentition, then definitely there will be a lack of space for the eruption of the permanent teeth, and we have to try some maneuver to create a space for developing erupting permanent teeth that are usually wider than the primary teeth. Here we can see there is no physiologic space present, and definitely the coming permanent teeth will see the shortage of space for their eruption. Next indicator is the unilateral or bilateral premature loss of deciduous canines with midline diastema. Here, as the canine has been lost prematurely and the space for the developing canine will not be present, then we have to plan planned extraction of certain deciduous teeth. Malpositioned or impacted lateral incisor may indicate to opt the serial extraction. Irregular or crowded upper and lower incisors again indicate the presence of arch line discrepancy. Localized gingival recession in the lower anterior segment show the crowding of due to the crowding of the lower anterior teeth are a definite indicator of the arch line discrepancy. Ectopic eruption of teeth and mesial migration of buccal segment, these are again few indicators for the arch line discrepancy. Contraindications to serial extraction will be the class 2 and class 3 skeletal malocclusions. If there is already a spaced dentition, anodontia or oligodontia, cases of open bite and deep bite, if there is a presence of midline diastema, class 1 malocclusion with minimum space deficiency will not be suitable for this serial extraction. Unerupted malformed tooth as dilaceration should not be cases with these problems should not be considered for serial extraction procedures. Extensive caries or heavily filled permanent molars, in that cases also these procedures should not be undertaken. Coming to the advantage of this procedure, because in this treatment is more physiologic as it involves guidance of eruption in the normal position. So results are more stable. Psychological trauma associated with malocclusion can be reduced as corrections are made at an early stage. It reduces the duration of multi-banded fixed treatment because due to the normal guiding of the developing teeth, they are more or less at their normal position. So there will be a reduction in the duration of fixed orthodontic treatment, and better oral hygiene can be maintained, thus reducing the risk of caries, and health of investing tissues can also be preserved. But along with those advantages, there are some disadvantages also there. This procedure cannot be universally applied to all the patients. And if we see the overall treatment time, that seems to be prolonged because the treatment is carried out in stages, and that can span from 2 to 3 years. And for the multiple extractions time to time, the patient has to visit the clinic so many times, and hence the ultimate patient cooperation is needed if we are going to opt this procedure. And again, as extraction space are created that close gradually, and there is a chance to develop tongue thirst in the extraction space. Extraction of buccal teeth may result in deepening of bite. If the procedure are not carried out properly, there is risk of reduction of arch length due to mesial migration of the buccal segment, and the ditching of space can exist between the canine and the second premolar. Also, the axial inclination of the teeth at termination of serial extraction procedure may require correction later on. Three well-known methods for serial extraction procedures are Duell's method, Tweed method, and Nance method. Duell in the year 1969 has given that the authentic inter-arch reduction of malocclusion, interception, and correction by serial extraction are accomplished in three separate stages for three separate purposes. Premature extraction of deciduous canine provides space for the incisors to assume normal position in an even alignment directly over supporting bone. Subjacent extraction of the first deciduous molar permits the desirable early eruption of first premolars. Here, at the 8 to 9 years of age, when C will be extracted, it will lead to the alignment of the incisors. Thereafter, D, that is primary molar, is extracted, and which will facilitate or accelerate the eruption of premolar. The final extraction of the first premolar make it possible for the canine to erupt in a favorable direction into the space formerly occupied by the first premolars. And in the third stage here, we can see when the first premolar eruption is accelerated, and this first premolar is extracted, and this will facilitate the canine to erupt in a proper place at the first premolar place. The interval between the extractions varies from 6 to 15 months. So, later on, Tweed in 1971, applying serial extraction to his arch length discrepancy cases, and has given a different pattern or sequence of extracting the teeth. Generally, he extracted the first deciduous molars first at approximately 7 to 8 years of age, then followed this with the extraction of primary canines and first premolars 1 year later at the age of 8 to 9. And he seemed to prefer to let ease exfoliate on their own if they were not delayed in this process. So, in the Tweed procedure, all the first primary molars are extracted first, and then after, all the primary canines and first premolars are extracted 1 year after, along with the C. The following the Tweed's method for the serial extraction may often showed a straightening and uprighting of the anterior teeth, an increase in overbite, and an alignment of teeth that permitted their correction in approximately 1 year to a year and a half or less of active orthodontic treatment. The disadvantages of Tweed method include there is too much uprighting of the anterior teeth, dishing in of facial profile, excessive bite closure, and it delays in the improvement in anterior irregularities. Third method, which is known as Nance method, includes extraction of all D's initially, and then extraction of all fours, that is first premolars, then extraction of all primary canines. And finally, the canine will erupt in alignment. D4C. Timing of guided primary tooth removal. Three factors may be applied by the clinician in deciding the optimal time for the removal of teeth in the guidance of occlusion. The effect of extraction of the primary tooth on the eruption of its permanent successor, the amount of root formation at the time of emergence, the length of time for the attainment of various stages of root development. As we have seen, three different methods like Duell's method, Tweed method, and Nance method. So for choosing which one is preferable and which tooth has to be extracted first, we have to consider all these three factors. Hence, there we can here the serial extraction procedures can be divided in groups, various different groups, where which tooth has to be extracted first and at which age is given. These are group A to 6, A to F. Then serial extraction in class 1 treatment, where the molar is in class 1. If there is a anterior discrepancy, these are named as group A. Anterior discrepancy in the form of crowding in the mixed dentition. Then the step 1 will be the extraction of the primary canine first, and then extraction of primary first molar in the step 2. Step 3 will include the extraction of first premolar and then multibanded treatment and retention. Then sequence is there CD4. If we say in as a mnemonic, it is CD4 for a group A. So step 1, extraction of primary cuspid. Here, a true hereditary tooth size jaw discrepancy is present, and radiographs can reveal crescent pattern of resorption on mesial of the primary canine roots. In step 2, extraction of the primary first molar is initiated. After the extraction of this primary first molar, the incisor crowding will be improved, overbite will be corrected, and because both C and D are already been extracted, the permanent first molar have been accelerated, and when the permanent first molar have reached 1/2 of the root length, in the next step they has to be extracted. Permanent cuspids have developed beyond 1/2 root length and are ready to erupt. These first premolar should be extracted, and this will facilitate the canine to erupt in a place of first premolar. So the typical result of serial extraction in this group will be relatively deep overbite, distal axial inclination of cuspids, mesial axial inclination of premolars, and residual space in extraction site that can be corrected by the multibanded treatment later on. An ideal occlusion, a minimal overjet overbite relationship, parallel cuspids and premolar roots with no spaces will be achieved after the final fixed orthodontic treatment that we can see here. Coming to the second group, where the anterior discrepancy is present, and here is some form of alveolo-dental protrusion. In the group A, there was a presence of crowding, whereas in group B, here is the problem is of bimaxillary protrusion, alveolo-dental protrusion. Here, the treatment is performed in 4 stages. First, extraction of the primary first molar, then extraction of the primary canine and first premolars. In step 3, multi-banded treatment and then retention. Extraction of primary deciduous molar. A minor irregularities of incisor teeth, alveolo-dental protrusion instead of crowding is the indication for this group. It will accelerate eruption of first premolar ahead of permanent canine as cuspid 1 beyond half root length and erupting faster than the premolar. In the step 2, premolars are extracted after erupting into the oral cavity along with the deciduous canine. So in the third stage, little mechanical treatment will be required and retention will be less crucial in the mandible as minimal irregularities was initially present. Third group is group C, where middle discrepancy is present because of impacted canines. Here, the tooth size or jaw size discrepancy is severe, causing premature exfoliation of the primary canine, and there is loss of space for the eruption of the permanent canine. Hence, the extraction of the primary first molars, then extraction of the first premolars, because C has already been exfoliated. and multi-banded treatment and retention. Next group is group D, where enucleation in the mandible is done. Here the fourth step involved in the step first, extraction of the primary first molars and enucleation of the mandibular first premolars are done simultaneously. Extraction in the step 2, extraction of the primary maxillary canine and maxillary first premolars, then followed by the mechanotherapy, and step 4 is the retention procedure. Here in the step 1, as extraction of the primary first molar and enucleation of permanent mandibular first premolar will be done when it is evident the cuspid will emerge into the oral cavity ahead of the first premolar. So extraction of the first deciduous molar and enucleation of premolar is done. That will encourage the distal migration of cuspids as they erupt. Then after extraction of the primary maxillary cuspid and permanent mandibular maxillary first premolar is done in the maxilla, because in the maxilla the first premolar emerged before the cuspids. Therefore, enucleation is less required in the maxillary segment. Then after, this procedure is followed by multi-banded treatment and retention and getting a normal well-settled occlusion. Another group is group E, where the enucleation in the maxillary segment is required. The treatment is done in 3 stages. In the step 1, extraction of the primary canine and primary first molar done simultaneously and along with the enucleation of the first premolars. That is followed by multi-banded treatment, and step 3, retention, is given. So, on occasions, the cuspids in both maxilla and mandible tend to erupt prior to first premolars. If this is the case, extraction of the primary cuspid, first deciduous molar, and enucleation of the permanent first premolar is done in both the arches, and that is followed by multi-banded treatment and retention. The group F will include where the procedure, if the permanent canines are erupting ahead of the first premolars, enucleation of the premolar should be avoided. If an opportunity exists to place fixed appliance at the completion of serial extraction. When the first premolars have attained 1/2 their root length, the primary first molar should be extracted. In step 1, extraction of the primary first molars. Step 2, extraction of the primary maxillary and mandibular first premolars and primary molars, primary mandibular second molars. Step 3, extraction of mandibular first premolars. Step 4, multi-banded treatment, and 5 is retention. So that were the different type of situations when according to the need we go for the planning which tooth we have to extract first and which tooth has to retain, whether we have to go for the extraction of C first or D first or enucleate. That all depends on the situation where the problem actually exists in the class 1 malocclusion groups. Serial extraction in class 2 treatment may be important, but extreme caution is not exercised. The malocclusion can be aggravated. Because serial extraction does not replace mechanotherapy, the primary objective of initial phase of interceptive treatment is to reduce vulnerability and injury to the incisors. When one mandibular second molar is congenitally missing, the clinician should proceed with serial extraction as normally done, extracting all 4 primary canines or primary first molars depending on the development. When the 4 first premolars have emerged, 3 of them are extracted. In a quadrant where the second premolar is missing, the primary second molar is extracted, and the first premolar then is moved into the second premolar site. This allows space for the canine to emerge. Hence, In the conclusion, we can state that malocclusion may be accepted or be treated in a variety of ways. Interceptive procedures can to some extent prevent or reduce the severity of malocclusion. In the treatment at early ages, the orthodontist can reasonably become redirector of growth pattern rather than solely concerned about the tooth position. Thank you.